introduce Dr. Michael Heath and Dr. Kachafs Atengu from Ghana. He is from the UK. They will introduce themselves in details and talk to us about COVID-19 vaccine hesitancy based on the research that they have done in Ghana. And I'm sure they have enough experience. If there are issues around Africa that you are interested in asking about, they would be able also to maybe hold you in discussions on the same. So thank you very much. You can decide who is starting. Then you will take about 40 or so minutes to make your presentation. Then you allow time for question and answer from the journalists. Then you respond to them. Thank you.
Okay, thank you very much indeed, Daniel. Between myself and Kachafs, we agreed that I would give an outline of the study and just give some indication of the provisional results that we found, and then Kachafs can provide some sort of better underlying context for those results within the Ghana setting. And yeah, apologies that within the UK we do switch from summertime to wintertime, so our clocks go forward and back, such that we ourselves can barely remember what time it is, let alone what time zone we're actually in. So the confusion is everywhere. So thank you very much indeed to media colleagues who are still here. So my name's Michael Head. I'm a Senior Research Fellow in Global Health at the University of Southampton in the UK. I'm based in the Clinical Informatics Research Unit, which is within the Faculty of Medicine. The unit itself does a lot around health policy, governance, informatics, handling data, digital health, in both high income and lower income settings. My areas of research around public health and infectious disease epidemiology. I've done a lot of work in Ghana over the last few years in particular, working with Kachafs and numerous other colleagues, particularly around neglected tropical diseases. We've, for example, published a paper on scabies in rural settings, and we've also got an ongoing study looking at digital health implementations during mass drug administrations for onchocerciasis. With COVID-19, we managed to secure a small amount of funding from the University of Southampton. There was an internal pot here at Southampton called the Strategic Development Fund. And within that, there were 3 streams to the research. One of which is led by Kachafs, so he can talk about that a bit more, but that's sort of liaising with policymakers and decision makers around the pandemic response and priorities going forward. We've also got a strand of the project which is led by Ghanaian colleagues who run a project called Opine World. So that's Kwabena Numar and Kingsley Osai. That's a platform where individuals can self-report COVID-19 symptoms on a mobile phone, and it can be any mobile phone. It doesn't have to be a smartphone. You basically dial a number free of charge and answer some questions. Do you have a cough? Press 1 for yes or 2 for no, things like that. And we can touch on those a bit more if you wish during this press conference. But the key, well, today anyway, part of that research is some vaccine hesitancy surveys that have been rolled out across Ghana and also in Togo too over the last few months. So we've run 3 surveys in Ghana and 1 so far in Togo. One in Togo was in January of this year. The Ghanaian ones, we ran the survey in August 2020, which is before any COVID-19 vaccines were approved. We ran a second survey in March 2021, which is when the Oxford AstraZeneca vaccines had arrived in the country. And we ran a third survey last month, so across the month of June. So we've rapidly put together some analyses available for the relevant policymakers across the Ghana Health Service and other colleagues in Ghana. And of course, last month, that also coincides with sort of the previous 2 or 3 months of media coverage around the Oxford AstraZeneca vaccine. And I think, as I'll briefly highlight in a minute, I think the impact of how those of us in the global north have been handling and talking about this vaccine as potentially having an impact elsewhere in the world in terms of how people are viewing it. But within the survey, the vaccine hesitancy and the willingness to vaccinate have varied a bit over time. I'm just going to bring up the figure in front of me so I can quote the correct figures. But in survey 1, back in August, the willingness to vaccinate in Ghana was 63%. Of the other 37%, actually 18.5% were unsure as to whether they'll be vaccinated, and 18% said they would not want to get vaccinated. Now, when vaccines had arrived in Ghana in March, we did another survey, and the willingness to vaccinate increased from 63% to 82%, which was looked to be a very good outcome. And the people who were hesitant, whether they were unsure or saying they would definitely not vaccinate, was greatly reduced to 17%. The most recent survey in June, the willingness to vaccinate dropped from 82% in March to 71% in June. And therefore, there were also corresponding increases in people who were unsure or definitely saying no. So that is a potentially worrying figure. It's still higher willingness to vaccinate than back in August, but the drop is obviously some concern, particularly as I think this is important because as the vaccine rollout globally is so slow and essentially unfair and inequitable, those of us who live in high-income countries have access to vaccines. In Ghana, I think it's about less than 3% have had one dose of a vaccine, and less than 1% have had 2 doses. And that's similar across most of sub-Saharan Africa, for example. So there is huge inequity in the rollout. What we need to be certain about is when vaccines do arrive in Ghana and are taken to different communities, that they are accepted and used. We don't want wastage because communities are uncertain about it. So we did look at reasons as to why people might be hesitant. And of the key reasons, among those who said that they were hesitant in the June survey, half of that group suggested they did not have enough information about the vaccine. So they essentially weren't quite sure about it. A third of the people who were unsure, the hesitant population in the June survey, said they believe the vaccine to be dangerous. And a fifth, 21%, cited government mistrust as a reason for hesitancy. We did then ask further questions around the Oxford AstraZeneca vaccine. 31.6% reported they had recently heard or seen stories about the indecision of the Oxford AstraZeneca vaccine rollout in other countries, particularly Europe and North America. And of that 31.6%, 62% of them suggested that these stories made them feel more worried about accepting the COVID-19 vaccines in the future. We did also look at other predictors of vaccine hesitancy. So my colleague here at Southampton, Dr. Ken Braxton, has run some logic regression analyses, which essentially allows us to look at what the key predictors are in terms of hesitancy. So actually, religious beliefs was one of the strongest predictors. So for example, Christian respondents to our survey were 2.0 times more likely to be hesitant than Muslim respondents. We also looked at political alignment. If you were a supporter of the opposition party in Ghana, the National Democratic Congress, then you were far more likely to be hesitant, 1.76 times more likely to be hesitant than if you were a supporter of the party in power, the New Patriotic Party. And there were elections in Ghana in December. I'm sure Kachas can tell us more about that, but there may be some kind of sort of still some tensions around the politics in Ghana, perhaps. Kachas can correct me if that's incorrect. And another predictor, we looked at education levels, and this was quite interesting because in higher income settings, you almost exclusively see that people with a higher education status are less hesitant towards vaccination. That's typically what we find. In lower income settings, the results are a bit more mixed, actually. Sometimes we see that more educated people are more hesitant, sometimes less hesitant. In our survey, in the Ghana survey, from the June version, the odds of expressing vaccine hesitancy were 1.6 times higher for university educated respondents. Essentially those who have undergraduate or postgraduate degrees compared to those who stopped at secondary school or less education. We also, I think one final predictor, we looked at gender, and in our survey, females were 1.6 times more likely to be hesitant than males. So those are some of the key findings from this particular survey. It's similar to some extent to the Togo report. I'll just give you a couple of findings from that. Bear in mind, this is so far a one-off survey done in January. So again, before vaccines had arrived in Togo, we will be doing another one in the next 2 to 3 months. So we will have a second time point to measure. But for now, it's just one survey. We found what we thought to be fairly high hesitancy in that Togo survey. 67.7% said they would be willing to be vaccinated. 25.7% said they would not be willing to be vaccinated, and 6.6% were undecided. So that therefore comes at 32.3% hesitancy once you include the undecided and the people who said they would not. We asked a follow-up question to the 25.7% who said they would not be vaccinated. So in that subgroup, almost all of them said the reason why was that they perceived the vaccine to be dangerous. That was 90.6%. With the next greatest reason offered being government mistrust at 40.7%. So clearly there need to be efforts around health promotion and public health messaging. Similarly, in Togo, we saw that gender was, females are more likely to be hesitant than males. And we also saw that those who trust the government generally also expressed lower vaccine hesitancy. So we saw similar findings on the whole between Ghana and Togo. I think perhaps I will leave the kind of the number crunching and the sort of the project summary there. We can pick up on any questions, but perhaps I'll hand over to Kachafs just to indicate some possible underlying reasons around these results and provide a bit of sort of context from within Ghana. So Kachafs, please do correct anything that I've misconstrued, but I'll hand over to you for now. Thank you.
All right. Thank you, Mike. Good morning to colleagues. I think Michael has covered generally a broad area of the whole work we're doing, looking at the 3 different strands to the study. But for our conversation this morning, we're focusing on the vaccine hesitancy and what's driving it. So I'm Kachafs Atengle, and I'm leading Pax Africa here in Accra, but working with government agencies across the continent to help enhance capacities for the uptake of research and other types of evidence for policy purposes. And in this very study, we've been working more hand in hand with health authorities in Ghana, including the Ghana Health Service and then the Ministry of Health. So the findings that have been produced from these studies have been shared with them, but it's just important also that we put in the public domain so that together we help enhance acceptance of the vaccine. There has been many issues of fake news flying around, and like Mike mentioned, some communities within the population seem to be having some fears, and he's touched on some of the specific ones. But we notice also that a good number of a good proportion of those comes from the sources of news that people have. So many people reported taking news from the internet and social media, which is a very like a good source, not good in the positive sense, but a more fertile ground for the dissemination of these news, because more people are in there, and most people for their busy schedules would not have time to watch the news or read the papers and all that. So once they get the opportunity to go online, and a good number of people also, although being educated, prefer to pick news also from social media as part of being critical as well. But from the findings, especially for this round of the survey, we noticed that the level of education comes out strongly. It wasn't so in the previous rounds of this survey, but in this very instance, we noticed that education is coming out strongly as a factor for the acceptance, in that people who are educated seem to be more critical um, of the vaccine program, which wasn't the case before. So we might want to dig deeper to understand what are the very concerns. But some of them have been indicated in the findings, talking about the various issues going on in the global sphere with the resistance towards the vaccine, the politics around the distribution, the safety issues that have been reported, even though these may have been blown out of proportion, because with vaccine developments, certainly not many people understand the technology. And so these are the areas that we think we need to have conversations on, for as many people to understand the technologies and the trials that have been run, and the fallouts from those in terms of the risks that have been identified. Obviously, if these incidents don't happen, we wouldn't know the risks that are involved in the trials, and then how to mitigate those. So take, for instance, the blood clotting issues that came up in the news. Certainly, it got people alarmed. Recently, we saw videos going around with people putting smartphones on their shoulders and claiming that it's the vaccines that they have taken that was causing the phones to stick in there. If they put it on the other arm, which was not injected, they fall out. So these are all claims, but it's just noteworthy to mention that one of those people who did one of those videos on social media, being a police officer here in Ghana, did a second video after that. I'm not sure if the Ghanaian media people here saw that, but he did a second video refuting the earlier video that he had done, that like acknowledging that it was false, it was a lie and all that. And this is very surprising. I believe health authorities and even the intelligence community, I mean the services, should take these issues seriously to investigate further. Possibly the health authorities working with such individuals who have come out to refute the earlier claims they made, work with them to correct such impressions that have been put out in the public. So I think I will pause here and then allow colleagues, if there are some specific questions, we can touch on them.
Okay. Thank you both. Thank you both very much. I think this is quite informative in terms of vaccine hesitancy, which is a big problem. And some of the reasons that you're giving, it's surprising that a police officer can actually be part of the people that are actually peddling misinformation about vaccines in Africa. But it's a major problem, of course. So I think the field is open. If you have any question, comment, you can ask. But you note that we have journalists here from Kenya, from Uganda, from Ghana as well. And I'm not sure, but I think from other countries as well. Any question? Okay, Joseph Opoku, are you trying to say something?
Yes. Good morning, Daniel, and good morning, friends.
Good
Obviously,
morning.
obviously, very much an insightful survey there. My name is Joseph Opoku. I work with the Multimedia Group in Ghana. So my question would be, the reference was made to misinformation to a certain extent and what the media would usually hear on major platforms, to a certain extent influencing how people perceive vaccines or otherwise. What would be your word to the media on how coverage of issues having to do with vaccination should go like, so that then one way or the other, that doesn't help fuel the vaccine hesitancy? So that would be one, your expectation in terms of the role of the media in helping avoid some of these situations. But secondly, was there any insight at all into the role that politicians have played in encouraging vaccine hesitancy here in Ghana? We've seen the president step up to take the first vaccine when it arrived in the country. A number of politicians have tried and made their efforts to step up and take this and do it very publicly, so that then the people are encouraged to a certain extent. That's what we've seen on the ground. But from your survey, is there any feedback on the role that politicians, their utterances, their actions may have played or not played in encouraging vaccine hesitancy? Thank you.
Thank you very much, Joseph. I think I would touch on that, and if Michael has some additions, you can do. Start with the role of politicians. I think at the very onset of the vaccination program, we saw the president take the lead in taking the vaccine publicly, which was good PR for the program. And I think a day or two after, we saw, was it the same day, that we saw the former president, who is leading the opposition party, also do that publicly together with their families, which was very good PR for the vaccination drive. But let's put this also in context that at the very beginning of the pandemic, government position had been more of a solo drive, in that the government officials were working together as a party in power. And so we noticed from the news that when the opposition, which is the NDC, approached the government to kind of form a multi-party team, kind of a COVID response team, there was a rejection from the government in party. The government, which is the party in power. And this sends strong signals to their followers. That, I believe, was the beginning of that division that had drawn from the program all down to the elections in December and the outcome of those. So across the 3 different rounds of this survey we've done, we have seen strong, association between the political parties and their willingness. The followers of the political or sympathizers. We don't know whether they are followers or real supporters, but at least we can say they are sympathizers of the political parties, aligned on these grounds, in that the sympathizers of the party in power seem to be more open towards the vaccination, whereas more of the sympathizers for the NDC even though it's not all of them, there is that strong association that we find from this study. So yes, the PR side have been done, but we think it would be better if we saw some national level collaboration, going beyond just the individual. And we notice, you may not also that for those PR works, the president did his vaccine. He took the vaccine separately at a different location, and the former president also did so at a different location, different venue possibly, and all that. So that kind of divided lines does not really help. We want to see collaborations. We want to see collaborations, which will send good signal, not only at the national level, but even at the regional and district community levels. Let's see party agents acting together. This is a national program. And so the more we are divided along the party lines, it affects our supporters and sympathizers and how much trust they will have in the program. Some have gone out to, make claims that the jabs that the president took was not a real one, and that some claim it was chloroquine that was put in him. Some claim it was water, and these are things that if we are working together, we can create more opportunity for building trust. Yeah, maybe I'll just stop on this, or I should go ahead with the second one. With a critical role of media. So
okay, go ahead, unless Michael has something to add to that, but I think you can go ahead.
Echo's hand is up. I don't know if it's related to this. If it says the next.
Yeah. Good morning, guys, and that was a rather insightful presentation. I'm sure this will go a long way to help us deal with these issues surrounding COVID, especially in Ghana. My name is Echo, and I'm from MX24 here in Ghana. It's a TV station here in Ghana. Now, we all know that we are experiencing what is known as a third wave of this virus, even though authorities are not too sure how to label it. Now, our cases have started going up. In the last couple of weeks, we've seen our cases hit the 4-digit range. At first, we were in the single to double range. We now hitting almost 4,000 cases. Few more deaths are being recorded. From your perspective, will you describe these increasing cases of COVID-19 and more deaths as encouraging or discouraging vaccine hesitancy? Thank you.
I guess, and in Ghana, so as you say, the cases are on the rise. We know that the Delta variant is present in Ghana at the moment. The Ghana Health Service has confirmed that, and that's the variant that was first spotted in India and caused that very, very tragic situation to unfold there. It's what we've had here in the UK, and continues to spread widely. Where Delta gets into a community, you often see the graphs go up at a very steep ascent. Cases go up very quickly. So I hope that Ghana is able to contain the community outbreaks, because otherwise Ghana might have a problem. Any African country where the Delta variant is present, if there are uncontrolled outbreaks, it's a problem. There are other countries in Africa, I think Namibia, probably Uganda, are struggling with their caseloads, and also things like oxygen supply as well. We've seen in India and some of the surrounding nations there, Myanmar, Burma, that they are lacking in oxygen. And that often makes a big difference between someone who needs to go into hospital and whether they make it or not. If they come out of hospital alive or dead, it's often oxygen is the difference. And if you have uncontrolled outbreaks, lots of patients in the hospital, then oxygen might be that kind of defining factor as to whether you have a death on your hands or not. In terms of whether, so Ghana needs to keep control of its caseloads, is the message there. In terms of whether that will influence vaccine hesitancy or not, interesting question. I don't know the answer, but reflecting on here in the UK, we've got a lot of COVID, tons of it. We pretty much always have done over the last 18 months. We've not contained our outbreaks at all well. Our hesitancy is very low here. Our willingness to vaccinate is high. I think partly historically, we're pretty good at our vaccinations on the whole. Our childhood immunisations, the uptake is high. The HPV, human papillomavirus vaccine that is given to teenage girls and boys, uptake is high. We don't have many well-organised anti-vax lobbies here in the UK, which I'm very thankful for, not like the US or Australia, for example, which do have strong anti-vax lobbies that are pretty horrible and quite intensive. So, but I wonder if the presence of COVID-19 makes us more likely to vaccinate because we can see the problem very clearly. Australia, as a counterexample, has kept COVID cases very low. I think they've been excellent with handling the pandemic thus far. But the problem they've got now is how to open up society again and get everyone vaccinated. There's quite a bit of hesitancy there. Again, probably in part because of the anti-vax lobbies, but maybe also they haven't seen how bad COVID-19 is when it gets amongst the population. Not really. So from the global north, as it were, from those high income countries, I would compare and contrast UK and Australia. I think I might pass back to Kachus to see if he thinks that might be reflected in Ghana as well. I will briefly come back to the question earlier on the role of the media, because this is obviously important. I think the UK media on the whole has done a pretty good job, particularly around vaccinations. It's been very supportive of vaccination. Where there have been scares, like the blood clot scares, it's reported on it, as it should. It's reported on it pretty well in terms of emphasising that vaccine adverse events that may or may not be causally linked to the vaccine happen anyway. All medicines have side effects, but the risks are very low. And if you get COVID-19, it's a very nasty disease. So it's better to be protected and have the tiny risk of an adverse event against the risk of getting infected and the much higher risk of ending up in hospital or dying of it, and long COVID as well, of course. And the media has, I think, been pretty good at putting that message across. I think also the Science Media Centre here in London has been extraordinary across this pandemic. It's been brilliant. I think journalists in the UK would say the same, as well as us experts. It's been able to connect both sides of the equation there. Build a lot of trust between journalists and us scientists. And I think that, I hope anyway, and I think we have helped contribute positively to the reporting by providing context and providing comments that the general public then read. So I was very pleased to see that there is a Science Media Centre in Africa now. I didn't know that until the London branch put me in touch with Daniel. So I think for journalists, use experts to inform your thinking and inform your content as much as you can. And people like Daniel are there to help with that side of things. So I think emphasize that the benefits of vaccination outweigh the risks is probably the top level message. And then kind of maybe your article will kind of unfold from there in terms of some of the context. But yeah, I think that's my kind of thoughts on the media and how and reporting around the COVID-19 vaccines. Kachus, I will hand back to you on one or two of those points for you to add a bit more, perhaps.
Sure, Mike, that's a good starter. And I will also continue from the media, the role of the media, adding that certainly the media should be more critical in assessing any piece of information that you get hold of. Ask more critical questions, whether it's coming from an institution or from a layperson who seems to, be an anti or campaigner. So I would request that the media engages more with the health authorities, specifically the Ghana Health Service. When we find any of those circulating videos and newses, spreading fake news or supposedly fake news. So cross-checking with the Ghana Health Service authorities, with the Ministry of Health, possibly also. We have real technical knowledge in Ghana that can speak to some of these, including we have the WACBIP, which is doing some great work on the genomics and all of that of the vaccine, the trends, they identified, they were successful in doing the genetic sequencing of the variants that we're discovering, including the Delta variant that we have now. So these are agencies that we can be getting in touch with as soon as possible. We find some of these, and the media is very much positioned in Ghana to speak to these authorities because we have relatively an open space for the media. So the keyword would be to get a lot more critical when engaging on these, so we don't contribute to the fake news and put out, fact-checked stories out to the public. Sometimes we can pick some of those consciously and produce some short documentaries on them, air them in our news and things like that. I believe doing such critical works will go a long way to help. Now, back to the question on whether the Delta variant has some possible impact on hesitancy. I think it's difficult to predict from this point, like Michael mentioned earlier. The reason being that other studies have looked at these, and particularly in Nigeria, where a good proportion of the sample that was studied acknowledged how dangerous the virus is and everything negative about the virus, but still were a good sizable number of them were still hesitant. So it's difficult to get, if we want to put that into this context, yes, people know from the news how dangerous the Delta variant is. And already we're seeing the signs of it increasing the number of positive cases. But it is also possible that this will not have any positive impact on a hesitancy in terms of reducing hesitancy. It's possible looking at what happened in Nigeria, but that is like an exception. It could be that certainly this will have some improvements in hesitancy, as in reducing hesitancy. But these are still early days. I believe we may want to look into some of those in the subsequent rounds of our study. But I want to mention also from previous studies that there's been some kind of association established between people who want to take the vaccine and whether or not they have had a close contact, maybe a family member or a friend who had the virus, who had contracted the virus, and how they have felt. So if you have those close people suffering through the process, certainly it will inform your need to put measures in place. So we notice that people whose close contacts have had the virus before are more oriented towards taking the vaccine. That's less hesitant to it compared to those. So with the increasing numbers on that side, with the increasing numbers were associated with the Delta variant, it looks like from that perspective, it looks like people may want to take the vaccines from that perspective. But like I mentioned earlier, it's also possible that even the danger associated with it will not make them want to take the vaccines.
Thank you for that. We have Kudo. Maybe go ahead, introduce yourself and ask your question. Then Otula will come next. Abu, please go ahead. Abu, your hand is raised, or is it by mistake?
I think he maybe is having.
How we can rely. Can you hear me?
Yes, we can hear you now. You can start again.
Okay, so I'm saying that this Abubakar from Multimedia Group in Ghana. I want to know how representative the sample of 30 million Ghanaians is for your survey, and to the extent that, we can say that this is how nationally representative the data is. Hello?
Oh yes, thank you for the question. So the sample size that we have is statistically significant in terms of how many we need to run a survey, with a 3% margin of error, as we call it. Essentially, the smaller the margin of error, the more likely it is your sample size is reasonable to be able to reflect the population. In terms of the people within it, we've made it as representative as we can, but with some limitations, which I will cover. So we used predominantly Facebook marketing to advertise the survey. So we were able to send that across Ghana. It's an electronic survey, so it needs someone to have access to the internet and a device. Within that, we do have, for example, a split of rural and urban, again, statistically significant numbers. But one limitation of our findings is that, so excuse me, we will not have huge numbers of hard to reach populations in rural communities who have less access to devices and to the internet. We still do have rural people within the survey, but that will be one limitation. And actually, I'll just add to that, over the last few days, we've managed to secure a small pot of money from the Neglected Tropical Diseases Support Centre, who are funding our onchocerciasis work, to bolt on the opportunity to carry out our survey in rural OT region in Ghana, to access some of these harder to reach populations. So we use community volunteers, like we do with mass drug administrations, to administer the surveys within their own communities. So we'll be able to get a sample size there that will give us extra data from a demographic that we probably haven't got fully represented within this population. But in terms of our methods and our recruitment into the study, those limitations exist, but it is a statistically significant sample size that is representative of the Ghanaian population. But yeah, we're very excited about the extra bit of money that we managed to secure from the NTD Support Centre. And we're also putting in funding bids to do more of that, that community data collection in rural areas, so that we can fully understand some of the similarities and differences across populations in terms of where they live and what information they get and what misinformation and good information they receive. But yes, an important question around sample size and so on. I hope that answers it.
So just to add to that, apart from those limitations, we tried as much as possible to have respondents across all 16 regions of the country, so no region at all is left out. And to mention also that gender, another constraint we had was in the gender distribution, because statistically Ghana has about 51 to 49% distribution, with the majority being the female. But in this study, across the 3 rounds, we noticed the female respondents have ranged around between 30 to 40%, which is still not up to the nationally representative sample size. But that also doesn't totally negate the findings that we're having. And so those are some constraints we're having, but like Mike mentioned, the subsequent ones, even with these, we have tried as much as possible to address some of these issues, just that sometimes it's a little difficult, and the more we want to spend time and resources to address them, the more it drags. But these are findings also that need to come out as soon as possible to address policy issues, but we are working on those to address them, to make it as much representative as possible going forward. We acknowledge, for instance, that when we put this out, we have about 3,000 responses, but about half of those don't end up completing all the questions that are put out to them. So in taking those out, those with missing data, we're left with the numbers that we're having, which hovers around 1,500 ish, as respondents. So these are some of the constraints that we've had to deal with in terms of making it as representative as possible. But we've tried as much to address those, including future doing this offline versions of the study where we can cover the villages as well.
Okay, Mr. Tula had something to say, but you can also, before he comes in, talk briefly about why do you think, or did you get any reasons as to why more women are showing signs of hesitancy than men?
I don't know the answer to that. We were able to describe the finding, but I don't know if we dug down into that to find out more. I'm going to pass on to Kachafs to see if he can provide a better answer than I can.
Yes, so across the 3 rounds that we've had, this has come out strongly, and we've asked ourselves questions, but at the moment, the most probable reason is because of our very, patrimonial society that we have, in which decisions are mostly taken by heads of households, and they kind of dominate, which are mostly men. So men dominating the decision space, and so it makes women less oriented to taking decisions of their own. Mostly they would want to consult with their men. And so if you want to take it even from that perspective, once the men are taking the vaccines, then probably the women should also be taken. But these are dynamics that we find it difficult to get hold of at the moment. And it's also worthy noting that this is not just in our studies, but it's reported globally by various studies that acknowledge that the gender is a key factor in vaccination acceptance, not even only for COVID, but most women, once there's a general rollout of a vaccination program, men seem to take those risks, risks much more than women would want to do. And these are studies that we might want to go into further to understand why those dynamics.
Okay. Yeah, just to add to that, actually, Kachafs mentioning that brought to mind that I'm co-author on a paper that is, I'll put the preprint link online. It's being reviewed at the moment, which took place pre-pandemic in Malawi, that was looking at attitudes towards routine vaccination. And actually that finding around hesitancy amongst women was found there as well. I'm just going to quote one line from one of the focus groups, where within the paper we say that further probing indicated the dominance of husbands in household vaccination decision-making as a factor that prevented turning intentions into behaviour. So actually what Kachafs discussed there, as you said, it is written in the literature, some of which I now realise I've written that literature as well. So thanks for reminding me, Kachafs. So that might well be one of the key reasons within our findings within Ghana. As Kachafs says, sort of the dominance of the male in the household, so that the female defers to the male decision making. So that may be one reason as to why, and it certainly is a plausible one. I will put the link into the chat to that preprint if it was of interest to anyone. But yeah, I'll pass back to Daniel. Thank you.
Thank you, Mr. Tula. Then we have Nana Yao.
Yes, thank you very much. First, I also have to thank you for the presentations. I think it is a positive effort towards trying to find out what goes on in this continent. The media tends to deal with broader issues, particularly when it comes to the issue of this virus, which has suddenly put journalists in an awkward situation, and they have coped very fast, from general vaccines to high-tech molecular biology issues. So we are just wondering occasionally that in Africa, the availability of vaccines, how do you think that affects the whole issue of immunization? Because I know cases where people go to get vaccines, but they find it is finished or will not be there. Or there are countries like Congo DRC, which had stocks of vaccine, but was following European Union policies, and they tended to hesitate as policies in EU changed, and some agencies are to see if it could be brought in Kenya or other neighboring countries. Those are some of the issues. And again, one of the interesting aspects is also from the biomedical world itself. When at certain levels, you find vaccines from Russia, there were talks of they didn't undergo through the third, I don't know, which should have been there. Then suddenly questions about the origins and Chinese. These tend to fuel a number of issues which the media has to deal with. So I don't know how that really affects the kind of research you do, because a lot of people rely on the media. If they hear that this is being done in the US or this is being done in the UK, it reaches very fast. It's become a globalized world. So we really would also be, for the sake of expanding the media's ability to report on these, is to put some of this into account, that if Africa was to make its own vaccine, how long would that take? Is that a contributing factor? Because India, which has a vaccine and the largest vaccine manufacturer, EU has been extremely reluctant to allow those who have the Indian vaccine to pass through EU. So these are some of the issues which maybe you didn't put into account, and not because, but they're issues which, if we discuss, may help improve the quality of reporting. So it is not just narrowed down for the media and those kind of things, because this is really quite a problem, because the mutation also, you talk of the mutation, and this is also generating a number of issues, which if the media reports, tends to generate a little bit more fear. But as a whole, I think the trend is positive for those media who are on the ground. The people tend to go, and most of the time they don't get the vaccines. Like now, there's been a shortage of vaccines, and keeping the data is also not very easy. So these are just general comments. I expected maybe you can also, if you chip in and we get a clearer picture.
Thank you. Yeah, no, a few interesting thoughts there. On the note of manufacturing vaccines in Africa, I mean that has to happen. It's something that pre-pandemic I was speaking with the World Bank about. They did a report called Money and Microbes, published it in 2018, that I contributed to, and so did the Clinical Informatics Research Unit where I'm based. And that was all about research readiness ahead of the next big outbreak, which, as it turned out, was quite prophetic, and that the next big outbreak was literally about to come. And it did talk there about the need to have kind of research registers in place, know where the skill bases are, and also to have the capacity to build, manufacture tools and products at scale. And clearly that is something that must happen, has to happen ahead of the next pandemic. Doing it now is tricky. As we're finding out with India being one of the world's major suppliers of vaccine, the minute India has a massive outbreak, that supply to COVAX and directly to countries dries up, or at the very least slows down greatly. I think running around trying to work out how to build a fire station when the world is already on fire is not the correct way to do it. We need to have the fire station in place before that fire starts. So preparedness ahead of the next time, we know there's going to be a next time, is massively important. And there has to be a huge amount of focus on equity and reduction of inequality, particularly from those of us here in the global north towards the global south, because we're at this point, we're holding all the vaccines, and that is not a good thing. So vaccine manufacturing in Africa, definitely. I've seen a few headlines over the last week or two suggesting that I think South Africa will have an mRNA vaccine, so Pfizer and Moderna essentially, site there. I think one or two sites, maybe Senegal, who are doing quite well when it comes to manufacturing products. There's a company called Melogic who do a lot with manufacturing diagnostics, and they have a site in Dakar that manufactures cheap diagnostics for a range of mostly neglected tropical diseases, but I think they're doing COVID tests as well. And certainly in Ghana, there are sort of startup companies that are starting to do some really good things around diagnostics as well. But diagnostics, medicines, vaccines. We need a lot of that. It needs to be manufactured within Africa for the African population. If there's any surplus, then it can come to the UK or wherever. But the paperwork, the contracts, the IP, the patents, all that side of thing, as we're seeing, there's a lot of arguments going along around the world on that. It's difficult to work these things out right now when everyone is running around screaming. On one of the other points about, well, access to healthcare, I think was one of the points, that you might have to go a long way to your health centre, and when you get there, it's shut, or they run out of vaccines, etc. Again, it's a good point, and we do cover that a little bit in the Malawi preprint, where I put the link in the chat, where participants in the focus groups and the surveys did respond, saying that there was a long distance to travel to the clinic, which will impact whether they're going to get vaccinated or not. And actually, sometimes health services, there's two different health services on the same day. There's a maternal health clinic over there and a vaccine clinic over there at the same time. Which one do you choose? Maybe you go to the maternal health one rather than the vaccine one. So organisation of health services and health systems is important. Access to healthcare is important as well. It might be that people are willing to be vaccinated, but they find it hard to do so for a variety of reasons, of which distance to the clinic might be one of them, or facilities and stock once you get to the clinic is another. So there's a lot to obviously unpack and unpick around the kind of area of willingness to vaccinate and vaccine hesitancy, but sort of the quality of the health service here to you is important. I'll stop there perhaps and hand over to Kachas for some further thoughts.
Yes, so very useful points about the availability of vaccines. And just to add up to what Mike mentioned earlier, that in this week, I think yesterday or 2 days ago, there were announcements by the European Union to provide about 1 billion euros to support vaccine manufacturing, in South Africa, which is good news because this is a very expensive venture, and African governments mostly find it difficult mobilizing resources for many projects. And so private sector-led initiatives would be very useful. And this EU support is actually to work with some laboratories in South Africa to get that done. So that is it. Equally in Ghana, the political class, right from the beginning stages, the president in some of his addresses have hinted some, kind of directions towards local production of vaccines. But the question is when is that going to happen? Because obviously government of Ghana doesn't have the resources to get that done. So these are things that we may want to push up on as media agencies to understand to what extent Ghana's preparedness is in terms of local production of vaccines, because like we're seeing in India, they are overwhelmed and so they cannot export what they are already having shortages of. And even though India is itself trying to secure as much for themselves, there are still stories of fake vaccines being given to people, even in India. So obviously those kind of news add up to the fake news, the anti-vaccines theories and all of those. So linking that to the hesitancy, already there are trust issues trust issues within the global governance system, looking at the history of Africa's involvement with the global community, taken right from colonial days and how some of the relationships that we've had. So these reflect in today's phenomenon, looking at COVID, for instance. So people are naturally not in favor of vaccines coming up from outside of the continent. So if we can really explore local production of vaccines, it would go a long way to help, there's anti-vaccination campaigns and the hesitancy that's associated with it.
So let's have Nana.
Great. Good morning, everyone. Hello.
Good morning.
Good morning. Go ahead.
Great. So I'm also Nanaya Rubin from Ghana. I'm a journalist as well. I have two quick questions. I think the presentation is very insightful, and the presenters have made it clear that they think it's time, or the media should do more in this campaign. My question is, in Ghana, for instance, the Ashanti region has a lot of cases now, if what we are hearing is actually true. Apart from that, Greater Accra has also seen some rise. And so my question is, from the data the team gathered, are there any insights into correlation between the number of cases in particular area and then the fact that people are hesitant to take the vaccine? Is that one, would it be a reason why we are seeing such a rise in Ghana and especially in the Ashanti region? The second one is there currently a lot of talk in Ghana about the Russian vaccines and how Parliament has set up committees to probe allegations of corruption in the contracts? All this, I think, is contributing to the hesitancy. And so, as scientists looking at, also trying to put their I want a good word, putting their stories into proper perspective so that we don't get conflicting infos from even the science space. That is also scaring a lot of people. Then the final one is, I'm happy we are urging the media to take a center stage of it. And then I think Michael mentioned the UK, London, and other networks in Europe doing a great job. Do you agree with me that in Ghana, or even let's just say Africa, the support the media gains when it comes to issues of this sort is very low, and so most of them don't have the resources to propagate some of this agenda? Don't forget also that most of these media houses are paying their workers, and so even if Corona is on the rise, they will still want to talk about politics where they will make some cash. They will want to talk about other things that will fetch the institution money more than paying more attention to a disease or a virus like COVID-19. And so is the survey also trying to say, how do we resource the media? Are you looking at that as experts? How do you resource some of the media houses so that they can spend much time in talking about this COVID issues than saying something within 10 minutes and jumping onto their political and other stuff that they make a lot of cash from? Thank you very much.
Can I?
I'll just quickly answer one of those. In terms of hesitancy or willingness to vaccinate by region, we have that data. I don't think we've analysed it in that fashion yet, so I don't think we can give you an answer to it. But actually, that's a really interesting point. I've just messaged my colleague Kenny Braxton just to see if we can do that and put that, because I think that would be a very interesting look at the data. In terms of media engagement, I guess a little bit what we spoke about earlier, the use of people like Daniel and the Science Media Centre, and the easy access to experts, so that you can get your comments back quickly. I think that is vital. So again, I think the Science Media Centre will and should have a big role to play across sub-Saharan Africa with links to the media. So I think that certainly has worked very well in the UK and probably has worked very well in other countries that have a Science Media Centre type body there. And I think also, certainly here in the UK, I get contacted a lot by our local news sources So you're all aware of the BBC. We have BBC local radio and local news for our area. I think, again, people like hearing voices of local experts, local scientists. So the University of Southampton and people like me appear quite a lot on the news when it comes to, well, for example, with COVID-19. There's about 5 or 6 of us that regularly comment on the local news and on the local radio. So again, I think if you can get access to your local experts, it's difficult across countries. I don't know how easy it is to access experts in the Ghana Health Service. I think sometimes the query is kind of passed up the hierarchy, and by the time someone finally answers it, the story was 5 days ago and it's not important anymore. So that's again where people like Daniel can help in terms of quick, easy access to the relevant expert. So that might be one way forward that might help yourselves in the media with putting out sort of commentaries and articles are as informative as they possibly can be. Kachafs?
Yeah, thank you, Mike, for the head start. I think the question around the Ashanti region and Greater Accra region being, having increased cases is very useful. In our current reports, we didn't take a look at that, but that's a good, outcome for us from this engagement. And I see Ken is in this meeting, so certainly after this, in the shortest possible time, I think we would have to work out across the 3 different rounds that we've had, look at hesitancy across the different regions to see how it's playing out at the regional levels. So that's useful. Taking on the controversy around the Russian Sputnik V and the vaccine hesitancy, I think. Yes, just like all the other controversies around the vaccination program, this is very important for us to consider. I wouldn't blame the media for that because their role is to report what comes out. So it's more of leadership by the authorities to consider, putting measures in place to implement the program as adequately as possible. And just this week, we know of a meeting that was held in Kumasi by the health authorities, the experts, the technocrats and all that, to evaluate the program, the vaccination program so far. So how things went, the successes, the lapses and all that would have been taken note of by them, and I'm sure that is going to inform the revision of certain decisions and how to approach things. It's just unfortunate that we have some of those negative news coming from the governor's perspective, but I think that is a message to the political class to get things done better. Now, in terms of support for the media, yes, you get the mail right when you talk about the media space being dominated by private media houses. The state broadcaster GBC is not very resourced to undertake some of the things, not just logistics, but equally in terms of capacity, competence, and all that. These are things that some of us have hammered a couple of times, but like you rightly mentioned, putting up a fund that is equally accessible by private as well as the state broadcaster would be useful, so that those who have the competency can access some of these resources to do quality works around communication and stakeholder engagement and driving home the key messages around the pandemic and the vaccination program and all the different components. So things like I see in the comments box, I see something coming up around options for solving hesitancy among the educated. So earlier on, I suggested, that the media will need to be very critical, and this is one key area, possibly holding discussions. Mike mentioned access to GHS officials. I think within this period, there have been very good engagement with the Ghana Health Service, but this has mostly been with the the Director General, who is just a single person. And so we'll need to look at more of a decentralized communication and engagement by GHS, which should help provide more space for this kind of critical exploration of the subject matter. And the media would need to be more innovative, producing short videos, circulating. I think a few of those gathered here have been doing some good work. So we should do more of the critical questioning types to ask, for instance, in this, our engagement where you ask questions about the regional distribution and how that is affecting hesitancy. Then quickly we can go back and then do that kind of analysis and put out there in the media, in the public. So these are kind of engagements that we should be having locally with our experts, the Ghana Health Service, the laboratories, the research institutions to, to question some of the messages that come out. And I'm sure the educated are ready because of their capacity to critique and analyze some of these things. When the media puts out some of these well-analyzed content, it will be useful in adding up to their acceptance of the program and the vaccine generally. So we need to do lots of work, and the media certainly is a key stakeholder in this at the national level and even down to community. We have community radio spread out across the country. These are useful resources that we can partner with. If there is a fund well resourced from the various quarters in the country, I think it will go a long way to help not just the state broadcaster, but private sector operators to help in this campaign. Thank you.
So Dr. Kachaps, as you can see, the media is very interested in qualitative information. As you can see, most of the questions are revolving around why, and trying to find reasons as to why are people behaving the way they do towards the vaccine. So maybe going forward, those are some of the factors you can also, the qualitative element of the research. Meanwhile, Matilda, do you still have a question? We have a few minutes to go, about 10 minutes or so. Matilda, I saw your hands up earlier. Do you still have a question?
Yes, I do. I have a question. Please, can you hear me? Is it better?
Yeah, introduce yourself and your media house.
All right, sure. Okay, my name is Matilda Maga. I work with Joy News here in presentation. You mentioned that some of the outcomes of the findings have been shared with the Ghana Health Service. I just wanted to know whether you've gotten some response from the Ghana Health Service, and to what extent are they likely to be incorporated, these findings, into their vaccine rollout?
Thank you. So yes, as we have shared widely with Ghana Health Service stakeholders, we've built up, certainly through Southampton, which has a long history of working with Ghanaian colleagues, including across the health service. There's a lot of sort of trust and networks built up there. So we were able to share the report with our networks, which includes senior colleagues within the health service, including regional directors and upwards beyond that. We've had responses of acknowledgement with that, but we do know that the meeting that Kachas referred to a minute ago, there was I can't remember the title of it, they did put out a media briefing note, I see, essentially a high-level Ghana Health Service stakeholder meeting. And within that, they referred to vaccine hesitancy as one of the key issues going forward. And we've had anecdotal feedback from senior colleagues that we know were at the meeting that our report was discussed there. And did form part of that discussion. So that's useful and good from our point of view. It's had some kind of immediate use and potential impact. But results like this go out of date quickly, hence why we do want to continue doing these surveys on maybe a quarterly basis as much as we can, so that we can keep providing Ghana Health Service and other relevant stakeholders with timely, up-to-date information. I think the use of real-time data has been, well, in some cases pretty good across this pandemic. We've seen how vital it is because the situation evolves so quickly. And if we can keep our data up to date, our own corner of the research world around these vaccine hesitancy surveys, then that will be of use, of better use to the Ghana Health Service. So it's being used and absorbed by senior colleagues in the health service, we know that. It's hard to quantify particularly the level of impact it has, but it certainly has reached the right places. Kachaf, do you want to add to that at all?
Sure, thanks, Mike. And so like mentioned by Mike, this meeting that happened has acknowledged, even though it may not be publicly put out there, we get the insider information that our report has been discussed in there. But one thing that I looked forward to seeing from that brief that was produced from that meeting was details on how vaccine hesitancy is going to be tackled by the Ghana Health Service, but that was obviously missing, even though the how appears in the other areas, but hesitancy didn't receive those kind of details. So these are areas that we think we can provide support to the health service on, and we will be getting closer to them to possibly co-produce some communication strategy documents around how to target messages to produce the kind of results that we're expecting. I'm not sure how soon the health service is going to take these on, but we would want to look out for some positive results from the next round of our studies. And yeah, we hope that we can have some impacts like Matilda, you were expecting.
Okay, thank you very much, both of you, Dr. Heath and Dr. Tengu. We have just about a few minutes. I think we can close unless there is a very burning question.
Quickly,
to ask.
In the chat
yes,
box,
go ahead. Yes.
Yeah, a question was put around whether there are some programs in Ghana that engage the youth and kind of community health officers. And yes, so the Ghana Health Service system is decentralized. It's one of the most decentralized services in the country. And it goes down to community health centers, what we call the CHIPs. And so these officers engage with community members as much as possible. But what we're realizing is that what we're suggesting is it shouldn't just be limited to the GHS structure, that it should be open to engage, especially looking at the insights we're getting from these surveys, because the hesitancy is coming from multiple angles. We're seeing the gender dimension, we're seeing the political dimension, we're seeing the religious dimension, we're seeing the location in terms of rural, urban, we're seeing education. So we need to be multi-pronged in our communication strategy. So this is what I was trying to put out, that we may want to do some targeting work, and certainly we should be. So to address that question, yes, there are programs, but the pandemic actually demands, what the insights we're getting demands that we kind of tweak our communication to make it responsive to the needs that we have today.
Okay, great. Thank you. Thank you very much once again. Those are really quite good. The issue of hesitancy is actually widespread, even in Africa, though one of the key challenges that is faced here is the lack of vaccine itself. So that in itself can maybe a contributing factor. So I think we appreciate your coming to share with us the results of your findings. We only hope that you can cover more of African countries, because countries like Uganda represented here quite well. Recently, they were talking about people being given fake vaccines, and you see that really is very dangerous, because you can now think that I'm protected, but yet you just got something else, which is not vaccine. It's even dangerous to your health. So thank you once again. Colleagues in the media, we hope if you publish something, you can share with us. We would like to keep track of some of these briefings that we hold, so that if there is a story that you publish, please do share with us. So just send us a link. We will appreciate. So thank you, Dr. He. Thank you, Dr. Tengu, for briefing us.
Thank you very much indeed, and thank you for running the press conference. And thank you to everyone for coming as well, and for staying on that extra hour. Your time is appreciated.
Thank you. Thank you all. Appreciate you.
Bye.